Don, are you okay to start?
I'm okay to start, sure.
Perfect. Maybe we'll get going. It's 8:33. Um, so we'll start with a land acknowledgement this morning as we welcome everybody to CHEO Department of Pediatrics Grand Rounds. I'd like to acknowledge that Ottawa is built on the unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So it's my great pleasure to introduce Dr. Don Boudreau, who's a physician educator and recently retired respirologist. He has previously served as Associate Dean of Medical Education and Student Affairs at McGill University. His research career has focused on the teaching of clinical methods, professionalism, and the humanities in medicine. He has a particular interest in the Aristotelian concept of practical wisdom and has recently published on clinical phronesis, which is a word that I didn't know anything about until I heard him speak at the Gold Humanism address at ICAM last year. And which leads me into telling everyone that he is the recipient of the 2024 Association of Faculties of Medicine of Canada Gold Humanism Award. And it was, in fact, that Gold Humanism address that prompted me to suggest an invitation to Dr. Boudreau to speak to us, because I learned a lot at his address, and it inspired me, and it inspired many others who were privileged to be there. So, with that, Don, welcome. Thank you very much, and I will hand over the mic.
Great. Thank you so much, Anna. It's a huge pleasure for me to be here with you. It's been probably 15 years since I spoke to a uniquely pediatric audience at the Montreal Children's Hospital, and it's many, many, many decades since I've taken care of children in a clinical domain. So it's really quite fun and exciting for me to be here. So thank you so much for the invitation. Now, how do I start my PowerPoint? Okay, great. Do you see my PowerPoint?
Yes, we do.
Yes. Okay, perfect. Okay.
Actually, I lie, Don. I see CHEO
No.
Pediatric Grand Rounds at McGill. That's got the first slide.
Oh, okay. So let me just see here. Oh, okay. So how do I
If you
advance?
use the arrows on your keyboard, they should advance the slide deck.
Yeah, no, it's not working. So should I stop? Should I stop share screen and go back?
Sure, let's give that a try.
Okay, let's just stop that. Okay, stop share. Okay, I'll go back and try again. Okay. No, it's still not working. Okay, so what's happened? Oh, okay, here. Now I have it. Okay, now it's okay. You see it?
I see the three-tiered
Yeah.
curricular.
Okay, perfect. I think we've got
Perfect.
it. Okay, perfect. Thank you so much. Sorry about that. So, yeah, so the title of my talk is a three-tiered curricular edifice. Uh, and as Anna mentioned, I'm from McGill University, and that little diagram there or picture is a picture of the Lady Meredith House, where my office is located. It's where the Institute of Health Science Education is located at McGill. So I have no conflicts of interest to declare. I'm not in a situation where I may be unduly influenced by secondary interests, and I do not have an affiliation with a commercial entity. So my learning objectives for this morning are to describe a very simple curricular framework to specify the needs of learners in a workplace environment, such as the CHEO, to define something called phatic communication, and to discuss very briefly practical wisdom, also known as phronesis. Three disclaimers before I start. I will be focusing on undergraduate medical education. However, the issues that I discuss are applicable to learners in postgraduate medicine, to residents, to teachers, and to all of the health professions. Secondly, the visual metaphors and the examples that I present will necessarily reflect my cultural lenses and positionality, and they do have inherent limitations. And finally, the model that I offer is very modest, and it is not intended as a universalist solution to any perceived ills in medical education. It's really aiming primarily to serve as a prompt for reflection this morning. Now, when students begin a clinical placement, they have a variety of concerns and preoccupations. For example, they are excited and they are hopeful. They are afraid of disturbing. They want to do good. They are concerned about looking stupid, especially around sick people. They are not certain what will be required of them. They may not even know what it means to be on call, and they surely will have heard that term, to be on call. And interestingly, they haven't given much thought to the idea that physicians have feelings such as being shy, being insecure, being afraid, being tired, being overworked, etc. So knowing these thoughts and keeping these thoughts and emotions in mind, I invite you to conceive of clinically based learning and workplace participation as occurring on 3 different levels. And this visual metaphor is adopted from a colleague of mine, Dr. CHEO, who works at the University of Bergen in Norway. Students enter their clinical placements on the first floor. However, teachers work and patients live, quote unquote, mostly on the second floor. So let us begin our virtual visit on that second floor. The second floor represents what learners assume that physicians know and do. On the second floor, students believe that medical doctors are busy with taking histories, examining and observing patients, ordering tests, documenting in charts and computers, doing procedures, making diagnoses, speaking to, and of course, very importantly in pediatrics, reassuring patients and their families, and initiating treatments. In contrast, the first floor represents the introduction and the orientation to a new environment for learners. And how that introduction and orientation unfolds is very much linked and tied to subsequent growth and development, and in a way, even to student survival in that new environment. The learner needs to be prepared in at least 3 domains: the pedagogic domain, such as being provided information on the specific learning objectives and what's expected of them; in the practical domain, such as details on who and when to call for help, and even very pragmatic and simple things like where's the washroom on the floor. And of course, in affective domains, for example, being greeted, being welcomed appropriately, being introduced by name to the team members and to patients, etc. So on that first floor, the new members of the team will want to avoid being overwhelmed. They'll want to avoid making mistakes. They do not want to be embarrassed or to seem to be embarrassed. They want to avoid being lonely. And interestingly, they want to be popular. They don't want to be unpopular amongst the team. And very importantly, they want to be accepted by peers, by nurses, by patients, families, and of course, supervising doctors and all doctors on the wards. Now that's the second floor and the first floor, very briefly. So now the third floor. The third floor represents capabilities that take a lifetime to master. On the third floor, through guided experience and guided reflection and much experience, the learner will come to understand deeply the roles and the routines. They will develop flair and confidence. They hopefully will become a leader. Hopefully they will become self-reflective. They will demonstrate courage, curiosity, humility. For example, they'll be able to fumble, to improvise, to recover from errors, and to grow from mistakes. And if they're very, very good, they'll advance the profession. So those are the 3 floors, very briefly. Now, what I'd like to propose is to give them a name. So to give a name to those 3 levels. On the first level, we'll call that the level of preparation. And as I mentioned earlier, it includes preparation for pedagogic and practical issues, but it also includes something that I refer to as phatic communication. Now, you may not have heard that term before. It's a very important term, phatic communication. What does it mean? Well, a phatic expression, which dates back to, I think, 1928 when it was first described, is a communication strategy that serves to establish and to maintain social relationships. It is that part of communication where ties of union are created, according to the person who described it. It includes gestures, posture, body movements, orientation, such as body orientation, proximity, eye contact, facial expressions, paralanguage. And what I mean by paralanguage, I mean the music of language or the prosaicness of speech. And it includes cliched phrases such as, "How are you? Lovely day, isn't it? Long time no see. So nice to meet you." It is the part of communication which breaks silence. It reassures speakers their presence is recognized, that they are welcomed and are being understood. Now, there can be failures of phatic communication. And these 3 examples are from a study that was conducted by Dr. CHEO and his colleagues, and I was involved in that study, conducted in a little community, a little town in Norway called Haugesund. So these are 3 students. Natalie is describing how the attending physician conducted their ward rounds. So Natalie says, quote, "Often they haven't even heard what you're called. They just call you student. For example, they'll say to his patient on the ward, 'May the student feel your belly, please.'" Rumi, recounting what it felt to be on the teaching unit, says, quote, "It felt awful. They didn't acknowledge me, and I thought maybe I should just leave. I felt like nothing, like a waste of space, like dirt under their shoes," he went on to say. 3rd student, Azari, describes how she was greeted on day 1 of her clinical placement. And I'll draw attention to this one because this one's quite remarkable. She says he, meaning the clinical supervisor, wasn't addressing me at all. So I thought, well, I'm just going to follow him, to shadow him or whatever. And then suddenly we were in the men's room together. So this particular student followed the clinical supervisor, who didn't introduce himself or herself, and led her into the men's bathroom. So my colleague in Norway actually refers to these episodes as not just failure of phatic communication, but examples of phatic damage. So how can we, as teachers and as supervisors, teach and nurture phatic communication? Because it is important. I'm not sure. I suppose we can continuously remind ourselves about its importance. We can certainly role model it, and we can try role plays. And perhaps you have other suggestions for me. So at the very end, for sure, we'll have time for questions and answers and comments. But I would like to share one thing that we've done at McGill. We actually have done role plays. So I'll share with you some of the scenarios that we've used to role play the notion of phatic communication with our mentors. So this is a scenario that we ask our mentors. Actually, we give them these scenarios, and they pick the scenario out of an envelope, and then we ask them to role play it. So this is supervisor C. This scenario is of a supervisor who is portraying a non-greeting actually total rejection kind of orientation. We've given him the name Dr. Kirby. Dr. Kirby has had a terrible morning. He had an argument with his teenage son before coming to work. Their home renovations are a distraction, and to top it all off, the family of a very demanding patient is waiting outside to complain. You, meaning Dr. Kirby, are now faced with the arrival of a student that you forgot was coming into the clinic today. You do not introduce yourself. You do not ask the student's name. You do not invite the student to sit down. You launch into an unpleasant tirade, saying things like, "Listen, I had no idea you were coming today. I can't cope with this. The faculty is demanding way too much of us, and it expects us to do all of this volunteer work. The past 3 students that I've had assigned to me have been disastrous. They were expecting to be spoon-fed and with very weak physical examination skills. The faculty is becoming extremely sloppy." So that's one particular role play. Scenario B, Dr. Kirby in this scenario is warm and invites the student to participate. He's visibly thrilled to receive the student. He says, you are expected and you are enthusiastically welcome. You introduce yourself, you identify your role, you say that you're the attending ward and the supervisor on the ward, and you introduce them to the senior resident. You ask for the student's name, you sit them down, you reassure the student that they can finish their coffee that they brought in with them that morning. You ask them what their learning priority is for the week and for the day. You explain that you are unfortunately too busy to assign a student right now, but that they will be integrated into the ward activities later on in the afternoon. In the meantime, you welcome them to shadow you in the clinical visits after you have met with the patient's family who's waiting outside. So those are some of the scenarios we give to the supervisors. We actually ask the supervisors to role play the student. So here's a scenario for a student. This is a student who's self-effacing, anxious, and lacking confidence. The scenario for the student is you are beginning this rotation with some apprehension. You are not confident with your basic skills, particularly the physical examination. You despise conflict and you tend to withdraw when faced with interpersonal challenges. You are anxious. If you are faced with a challenging encounter or you sense any mistreatment, your level of anxiety increases and you start to tremble. You stay silent and you look for ways to escape the situation. And finally, another scenario, this is of a student who is mature, congenial, and self-composed, very confident. The student's scenario is you are an eager and curious student who is looking forward to the rotation. You are respectful, polite, and a good listener. If you are faced with challenges, for example, an unwelcoming supervisor, you'll take it on the chin and you will not lose your temper. You deal with challenges with equanimity and you are proud of your self-control and of your survival skills. So we give these role plays, we give these envelopes in which there is the scenarios to the mentors, and we ask them to role play both the supervisor and the student. And we've done that a couple of times and we found it very useful. And it's interesting, the supervisors tell us that they learn as much by playing the student as they do by playing the supervisor. So that's level 1. In terms of level 2, I'm calling it participation in physicianship-related activities. And at McGill, we've used the term physicianship. Other schools call it physicianhood, to refer to the character, the knowledge, the skills, and the behaviors that are required to fulfill the roles of the physician as a healer and the physician as a professional. So, of course, these are all the things that we've talked about on level 2 before, such as doing physicals, taking histories, making clinically reasoning, making differential diagnosis, initiating treatment, and so on. So, of course, those strategies to teach and to nurture physicianship or physicianhood, I'm sure they're all very familiar with them. Over the past decade or so, we've introduced new strategies such as the longitudinal integrated clerkship. We, of course, have been using patient actors and patient partners, simulated patients. Increasingly, we're using in situ simulations on the wards. We also teach the social contract. In other words, we offer students service-based learning opportunities, electives in population health, and occasionally initiatives in global health. And to various degrees, we try to integrate the humanities in our teaching programs, less so in clerkships, of course, but we do try to introduce in the mentorships, contact with visual arts, with the classics, and we teach narrative skills or narrative competence. And I'm sure that there are other strategies that, again, at the end of the talk this morning, we can probably have a conversation about what are some of the other strategies that you use to teach and to nurture physicianship. I do have one question, which to me is a very burning question, and that is, I'm not convinced, I'm not sure, I don't know where technology-enhanced education, particularly computer-based patients, augmented reality, and things like artificial intelligence learning companions will fit into the picture. I'm sure that they'll have a role to play in the future. I think the jury's still out on this, but again, we can perhaps discuss that later on. The third level, I'm going to label as phronesis. What do I mean by phronesis? Well, Dr. Anna Karowska referred to it in her introduction. It is a Greek term. It originates from Aristotelian philosophy. It really refers to practical wisdom or practical reasoning. And it's become increasingly popular, increasingly important in many practical endeavors. There's a huge amount of literature now on the role of phronesis in education, and even in management and economics, particularly in law, and political science, and in medicine. Basically, it refers to the capacity to judge what is at stake in a situation, to recognize what constitutes a good outcome, and to choose and to act on the correct means to bring about such an outcome. So it's really referring to the virtues of medicine. A popular tagline for phronesis is the right person who knows when to do the right thing for the right person in the right way and for the right reasons. Now, I don't have a lot of time to talk about phronesis, but there are books written about it. One of the books I find particularly useful is from a colleague at McGill, Dr. Ann Kinsella, and her colleagues have written a book called Phronesis as Practical Knowledge. And in that book, they refer to some of the aspects of a phronesis-informed curriculum. So very briefly, I think that a curriculum that is phronesis-informed would address the following 6 issues. Number 1, of course, is best learned through experience, and experience that is accompanied by guided wisdom or guided mentors. It is relationally oriented. So it provides access to appropriate role models, to mentors, and to coaches from the get-go. It is ethically informed. It focuses beyond the instrumentalist purposes of clinical practice, and it includes discussions about the moral purposes of the practice. It recognizes that reflection is a cornerstone of wise practice, and it makes extensive use of narratives to convey what phronesis looks like. It emphasizes discernment and practitioner judgment, and it recognizes the importance of and creates safe spaces to discuss the aporias of practice. And what I mean by aporias, I'm referring to the unknown, the uncertain, the contingencies, and the complexities of medical practice. As you all know very, very well, medical practice unfolds in a terrain of unknowns and uncertainty. So, to emphasize the points that I've been trying to make this morning, I'd like to present what may be seen as a possible antithesis to phronesis. Now, I'm sure that many people in this audience, especially those from an older generation, from the baby boomer generation, have heard of the book, The House of God. And if I were there with you in presence this morning, I would ask for a show of hands, and we could see that I'm sure over half of this audience has been exposed to the novel by Samuel Shem called The House of God. Now, that book was a brutal description of the practice of medicine. Of course, it was done with good intentions, but it was a very negative portrayal of medical practitioners. Some of the rules in his book, in the House of Gods, included things like placement comes first. Gomers go to ground. And what he meant by Gomers is get out of my emergency room. What he was referring to is that those elderly and very frail patients would often fall to the ground and would have broken hips. So Gomers go to ground. If you don't take a temperature, you can't find a fever, so don't take a temperature. And the delivery of good medical care is to do as much of nothing as possible. So again, these are very, very negative. Again, he was doing this to show the negative aspects of medical education when he was a resident. But I think that we should forget the House of God and what I'm proposing here. And this is a presentation that I gave when I received the Gold Award. I'm thinking that perhaps this modest counterproposal of a 3-level curricular edifice could be referred to the House of Gold. And the 3 levels I've labeled with the 3 Ps. So again, on level 1, preparation and including phatic communication. Level 2, the standard traditional behaviors and skills and characteristics of the physician. The physician is the healer, the physician is the professional. And phronesis, those aspects of the virtues of medicine on the 3rd floor. Now, I'm reaching towards the end of my talk. I'd just like to say that this 3-tiered edifice, which I've outlined, is of course an oversimplification. As I said earlier, I do not present this as a fix all to all of the perceived ills of medicine or medical education. And of course, our professional lives are experienced continuously on those 3 floors. It's not as if we are on the 1st floor on Monday and then the 2nd floor on Tuesday and the 3rd floor on Wednesday. But I hope it can serve as a useful heuristic. And one thing I'd like to leave you with today is that we shouldn't forget the behavioral imperatives, the expectations of us as physicians, as clinical supervisors on that 1st floor, on the ground floor. And I'd say that that's particularly important if we're having a bad day, such as the role play of the Dr. Kirby that I presented to you earlier. Dr. Kirby was having a bad day. He'd had a fight with his teenage son. His home renovations were going terribly. And I think if we're having a bad day, I would ask us, all of us, to remember the importance of phatic communication. And contrary to that, on the reverse side of the coin, if we're happen to have a good day, maybe we should try to spend some time with our students on that 3rd floor. On that floor where we're asking our students and giving them opportunities to reflect on the aporias of medicine, on the uncertainties that they've experienced that day and how they've handled it, and so on. So I've shared with you some of the golden rules of the House of God. Perhaps some of the golden rules in the House of Gold might include things like we should always introduce ourselves to our patients, but of course to our students as well. We should never say, like in that clinical placement, clinical teaching unit in Haugesund in Norway, we should never refer to students as student. Can the student examine this patient? We should never say there's nothing that I can do to a patient. There's always something we can do. We should recognize and act on Arthur Frank. I'm Many of you may know Arthur Frank. He's a medical sociologist, now recently retired from the University of Calgary. Doctor is when you can do the least for me that I need you the most. So I think that particular invocation of Dr. Frank's is very important. And we should make the welfare of the patient their supreme law, the supreme law. So salus aequoti suprema lex, the Latin expression of our supreme law is the welfare of our patients. And I'm finished with this one. I recently visited Taiwan and was given this gift. You know, when you make a visit, you're always given little gifts, but this is the one that I think is the most precious for me, the one that I treasure the most. It's actually, of course, it's in Mandarin, but actually it's from a philosopher by the name of Hu Shi. And the translation is, in pursuit of knowledge, skepticism or suspicion prevails. And that's part of the medical model, if you wish, the biomedical model, part of scientific methodology. In pursuit of medical knowledge, skepticism or suspicion prevails. However, in clinical medicine or in human relations, trust without suspicion is always foundational. So I'll leave you with that. I'd like to thank Dan Peterson Escobedo and Dr. Tamara Carver for their assistance with my graphics. I'd like to thank my colleague from Norway, Dr. Edvin Skei, for his visual metaphor of the 3-floor clinical teaching unit. And a very special thanks to Dr. Abraham Fuchs, former Dean of the Faculty of Medicine, who very unfortunately, I'm sad to say, passed away 2 days ago, for his ongoing support of me personally, for his mentorship as a phronesis person, a phronimoy, for his role modeling, and for his assistance in creating this PowerPoint presentation for me. Thank you, Abe. Thank you all. And I'll stop sharing here. Some references.
I don't,
thank you very much.
Don, I don't see your,
I'm sorry?
sorry, Don, I don't see your PowerPoint.
I'm sorry, I can't hear you, Anna, I'm sorry.
Sorry, Don, I'm having some issues, but I don't see your PowerPoint, so no references have come up.
Oh, okay, I can put them back on. Should I put them back on now?
I think it would be good, and then we can maybe take some questions.
Yes, of course. Let me just see here, share. Yeah. Okay, yes, here's the references.
There we go. Thanks very much, and our condolences for the passing of Dr. Fuchs.
Yes, I'm sorry. Thank you. It just happened on Monday, so it's very, very
fresh.
Thank you. Yeah. Can I stop sharing now, or?
Yes. Why don't you go ahead, and maybe we'll open up the floor for questions. With apologies to everybody, I'm having some technical difficulties, so I can't have my video and my audio on at the same time, it seems. Any questions from the floor from anybody?
Yeah, perfect. I purposely, let a lot of time for comments and questions.
That's great. Maybe I'll start with one while folk get a chance to think. When I was listening to you talk about the sort of the level of phronesis, Don,
yes.
There were sort of whispers of the new sort of the new one of the new catchphrases in medical education of adaptive expertise.
Yes.
Can you comment on, is it the same? Is it different? Do they intertwine? Do they overlap?
That's an interesting question. I've never thought of it. But I think clearly they overlap. I would think that adaptive expertise, which I don't know much about it, but I would think it would be a modern and a contemporary version of phronesis in many respects. But I think adaptive expertise to me invokes or suggests performance-based skills. Like, I may be incorrect, and I may not be doing it justice, but to me, it really implies skills and performance. Whereas I think phronesis also um, suggests that the person, the being of the person changes as well. So I think, yes, I think that there's a huge amount of overlap, and thank you for suggesting it. Um, I think that, in the research that I've done on clinical phronesis, the notion that a physician continues to learn over time and is continuously adapting to context and recognizes context is one of the ingredients and one of the characteristics of the phronimoi, if you wish. So yes, I think there's a huge amount of overlap. Thank you for suggesting that, and I'll keep that in mind for sure.
There's a
Oh yes.
comment from Eileen. Would you want to expand there, Eileen?
Sure. Thank you very much for your talk. My name is Eileen McBride. I'm a pediatric hematologist, oncologist, and a lab physician. So I've recently been doing some teaching at the medical school level, and I've noticed this in my clinical practice, but I also noticed it in the simulated patient groups, that people are no longer shaking hands. Students, residents are no longer putting out their hand to shake a hand since COVID. And I find this to be disturbing, a disturbing trend, not only in church, but in clinical practice. And there's no alternative. I worked in the Middle East for many years where shaking hands was not necessarily appropriate between genders. However, there is a motion of putting one's hand on one's heart as a gesture of welcome. And I'm wondering about your comments if you've seen this. And I personally find it very difficult and have been teaching that respecting a patient or parent's choice not to shake hands is, of course, appropriate. But I feel like that initial skin-to-skin contact is missing, and I feel it's a real loss. I'd love to hear your thoughts on that.
Well, I couldn't agree with you more, really. I think it's a huge loss. I can understand it. One has to respect the patients, obviously, if they don't want to. But there's so many things. I mean, my brain's on fire as you were mentioning this. There's so many things I could share with you. For example, when we introduced during COVID, or no, actually it was before COVID, but when we decided to have clinical standardized patients or simulated patients, I should say, in one of the physical areas of the medical school that did not have sinks for hand washing, we made a conscious decision not to do it because we thought having a sink for hand washing was absolutely critically important, that we should not have rooms where we teach communication skills and encountering patients, that we should not accept a room without a sink. So for us, it was absolutely critically important. And the reason for the sink was to wash hands, so that you could shake hands. So that's one thing that pops in my mind. Another thing that, as I said, my brain's on fire as you mentioning this because it's so important. And one more little anecdote that I'll share with you is that I'm recently retired from clinical practice. And one of the last patients that I saw was a patient who unfortunately had to give bad news that this patient had lung cancer. The patient also had severe deforming rheumatoid arthritis. And I remember, I'll never forget this at the end of my living days. I wanted to shake hands because I wanted to touch him because I was at the time of giving this bad news. And I was struck that I wasn't able to, I stopped grabbing his hands because of his arthritis, and I thought I was going to hurt him. So because I felt that I could not hold his hands at that moment, I ended up hugging him instead, which was a fantastic moment, of course. It created a huge bond, and we both were able to cry at the moment because I was able to hug him. So I guess the message behind that anecdote is that, you can also touch in other ways, right? So if you can't touch a hand, perhaps you can put a hand on somebody's elbow or somebody's shoulder. Very routinely, as a respirologist, I was a respirologist, when I would listen to somebody's lungs, particularly posteriorly, I would almost routinely put a hand on the shoulder. And the reason for the hand on the shoulder wasn't that I was trying to study the patient. They were fine. They were not ataxic. It was my way of establishing physical contact while I was doing the auscultation. So I couldn't agree with you more, Dr. McBride. Thank you so much for bringing it up. I think it's so important. And if we can't do it, we have to find other ways of making skin-to-skin contact. Yeah. Thank you.
Thanks. Any other questions? I see Mark.
Yeah, thank you, Dr. Boudreau. I actually was at your Gold Humanism Award lecture in the
Oh, thank you. Oh, sorry, I'm being repetitive. I
No.
apologize.
It was great to hear it twice. I wanted to ask,
Sure.
with the role plays that you
Yes.
described for your faculty,
Yes.
is this a mandatory requirement for all
No.
your faculty to do? And
No.
if not, then my question is, how do we motivate faculty to participate in these types of professional activities, particularly knowing we have a variety of faculty and some who demonstrate, these traits and skills you describe so well, and others who I think, could be reminded of some of these important humanistic skills. And how do we encourage those people to participate in these sorts of events?
Oh my heavens, what a big question, isn't it? So just to answer your initial question, though, yes, no, they're not mandatory, of course. It'd be very hard to make those kinds of things mandatory, I would think. But they're encouraged. We offer it to our mentors. So in our program, all the students are given a mentor for the entire 4 year of the program. We call them the Ozer Fellows. So the Ozer Fellows are invited to participate in these workshops. And I'd say that perhaps, at the moment, in steady state, we have about 130, 140 Ozer Fellows at any one time. And of those 140 mentors, I'd say about half of them, participate in the workshops. So, we do have some impact, we do, because there are many people who do volunteer. And they're interesting. I mean, these role plays are fascinating. The faculty, whether they're role playing the student or whether they're role playing the supervisor, they learn a lot from it. But you've raised an issue it's been a conundrum for faculty development from the get-go, right? Is the people who need it the most are the ones who tend not to attend, and the people who need it the least stay away, right? I mean, are the ones who volunteer. So I don't have a solution. I don't have a solution. I think we have to just promote it and speak amongst ourselves and share that this was a learning experience for us and hopefully motivate people and encourage people. But I don't have a solution for you. Perhaps somebody else in the audience does. Yeah.
Yeah, I think it's an important question, and
Yes.
share with our department. We still hear from our students exactly those scenarios that you
Yes.
presented of in this day and age, our students will report back that no one talked to me, no one introduced to me, no one introduced themselves, and I just kind of stood in the corner and kind of stayed out of the way for the afternoon and left.
Absolutely. Absolutely. I mean, it is damaging. So as my colleague says, it's fatigue damage. It's not just a failure. We can call it as fatigue damage. And, one of the roles that I hold now in the faculty is I work in the Office for Respectful Environments. And these kinds of scenarios, they do occur. They occur often, and they do affect the students. It robs them of confidence, and they question themselves as to their abilities, and all those concerns that I mentioned at the beginning. Should I be there? Did I make a mistake coming here? Those things, they surface, and it causes a lot of damage. So, I mean, the one thing we can do, of course, if we have a faculty member who has being identified as, being problematic in this regard, and has accepted the fact that they could do better, well, we can, offer them these scenarios or these kinds of workshops. And so, but you've raised an important point. I wish I had a solution. I don't. Thank you for the question.
Don, I actually have a follow-up question.
Sure.
I don't see any other hands. Is there, do you know if there's any work being done for the role of maybe coaching students along the way? Because we were all students. Every
Yes.
faculty was once a student,
Mhm.
and we would have not enjoyed being treated like that. Is there any role being done in sort of starting at the student level and coaching
Yes.
learners as they move through the phases and then into faculty around
Yeah, that's a good point.
that
Yeah, we
kind of
do that.
communication?
Yes, we actually do that. So in our third and fourth year, we actually have scenarios where all of the students is mandatory for the students. So the students come to the simulation center and they are exposed to these kinds of scenarios. So they are exposed to physicians who misbehave, not just physicians, nurses, other healthcare professionals who misbehave, and so they're two of the objectives. One of the objectives is to prepare them, of course, for these scenarios, so that they're able to, if they ever encounter them, that they're able to deal with them in a positive way, so that they know that so that they understand that they can sometimes make a contribution themselves in a negative way to the scenario, and how can they make a positive contribution. But there's another objective, and the other objective is that they are going to be the future generation, right? These students, these senior medical students, within a year are going to be the senior residents or the junior residents, and then the senior residents, and then the chief residents, and then the faculty. So the message is, look, you are the future. So please, these scenarios, keep them in mind 3 or 4 years from now. So we're hoping that I'm not sure if this is the right term, but maybe a Trojan horse or a culture change, maybe by introducing these things very early on, that will have some impact down the line. Yeah. So we do it for the students. So it's mandatory for the students. It is not mandatory for the faculty, but perhaps it should be. Perhaps the faculty should accept that for every new faculty member, that they have to undergo these kinds of faculty development workshops.
I don't see any other hands, so
Very
we'll
good.
bring Grand Rounds to a close with gratitude.
Thank you.
To you, Dr. Boudreau, thank you so much for sharing your work with us, and
Thank you.
wishing everybody a great day.
Yeah, and thank you so much for the invitation. It was really special for me to speak to this particular audience. I'm not sure why. It's I guess it's been so long since I've taken care of children and been in a uniquely pediatric environment. You're such a wonderful group of physicians, and you're not the ones who are causing our problems in our institutions. It's not the pediatricians. It's not the children's hospitals. It's quite the reverse. You're often the little choo-choo train that could, So
We are.
thank you. Have a
Thanks
good
so
day.
much. Have a great day, everybody.
Bye-bye.
Thanks, Don. Bye-bye.
Bye-bye. Ciao. Bye, everybody.